Emergency Medicine Programme, and we have the President of the Irish Association for Emergency Medicine with us also. To this EMP webinar on really the future of emergency medicine services with COVID, because we know we can't see anything like after COVID just yet. I'll have the next slide, please, Erica. I'd like to thank RCSI, including the President and the team, particularly Erica, for facilitating this, and those of you who have registered to attend. That's the programme there. This is me opening up really with what unscheduled care is about, what it used to look like way back before COVID. Am I on mute?
No, we can hear you.
Oh, great. Okay. So somebody, sorry. What it used to look like before COVID.
Sorry, Jerry, can I just interrupt for 1 sec? There's still people saying they can't get in. Okay, can we just make sure everyone's been lined up? I don't know, is there a queue, Paula? Thanks. Sorry, Jerry. Go ahead.
That's no problem. I don't think what I'm going to say in the next minute or two is going to be vital to the next hour, but hopefully people will be in the next few minutes. So if you look at the agenda that we have there, Mr. Robert Morton, the Assistant National Director for HSE Acute Operations, the bricks and mortar man in strategy and planning, has very kindly agreed to speak to us in recognition of the fact that whatever is different, we're going to have capacity issues. Once we have physical distancing in all aspects of healthcare, once we have it in unscheduled care, the unpredictable side of things, well, then there is a need for capacity, and Robert is going to speak to us about plans for that. The next two speakers, John Ryan and Ash Butt, are deliberately chosen as John in a big, busy urban Model 4 department, and Ashraf working extremely hard in Cavan General Hospital. And just to compare and contrast the capacity and resilience issues in both of those hospitals that were brought out by COVID, and how really any kind of solution we have may have to be nuanced, for one thing for the larger urban centres and another for the less well-staffed centres in smaller towns. Emily O'Connor, hi Emily, President of the Irish Association of Emergency Medicine and consultant in emergency medicine in Connolly, is going to speak to the IAM recommendations for working with HSE for resetting care in Ireland's emergency departments. Vida Hamilton, I've already seen and welcomed online. Thank you, Vida, the National Clinical Advisor and Group Lead for HSE Acute Operations and also a consultant intensivist in Waterford. I'm going to speak about the drivers for change. And then I would intend to kind of bookend it by picking up where I left off and maybe talk a little bit about the future and invite questions and answers. Next slide, please. So the next slide is Erica. Yeah, thank you. So that's just a picture really of different aspects of patient flows in unscheduled care. We all talk about shifting to the left, keeping as much in the community as possible. So you can see the parent minding their sick child, top left there. You can see the patient, their general practitioner. You can also see in the middle, sometimes the bad thing happens and the hospital needs to come to the patient and get the patient to a big centre as rapidly as possible. Next slide, please, Erica. So that's a kind of schema to represent primary and pre-hospital care. That's the amount of what I would call healthcare transactions that go on in primary and pre-hospital care. And it probably should be even bigger, it just wouldn't fit on the slide, in comparison to that which goes on in the hospitals. But really, I think we need to remember there's a Venn diagram element of overlap, where some of the stuff that happens in primary care might be presented to an emergency department or an acute medical assessment unit. And there is an argument to be made that you treat the patient where they fall down, including, as I say, bringing the hospital to the patient sometimes. The next slide just shows the two principles. The second one is the same as it ever was, but the first one really is the biggest driver for change that we have at the moment. And this is the huge headache, I think, for those of us working in unscheduled care in general, which is how do we adhere to the principle of physical distancing and demand-led service, where people turn up without appointments. The next 7 slides, I'm going to move fairly fast through. If I could have the next slide, please, Erica. These are some SDU figures, the Special Delivery Unit that were presented to the ED Task Force earlier in the year. And each of the next slides speaks in the different colours. No, sorry, we just go back one, Erica, please. Speaks in the different colours of the years 2017, 18, and 19. You can get used to the colours there. And it shows you, Erica, if I can go back 2 slides, please. That one, yes, please. Thank you very much. That's great. Okay. So that's all ED attendances. You can see they were on the way up. And now the next three slides break them into pediatric. You can see there's a peak up there in 2019 and speculative reasons for that. The next slide is young and middle age, which really is not peaking. It's, if anything, going down. And the next slide then, one we all speak about, the elderly demographic, which is showing a similar picture to pediatric really. The next slide, please, Erica. This is the way things were immediately before COVID. So these show in the different age groups, the conversion rate is the number of admissions over the number of ED attendances in a 24-hour period. So you can see there, typically it's in the mid to high 20s on the right there for all patients. The young to middle age group is in that bracket. Pediatric conversion rate is much lower, but there on the third set of columns, you can see that the over 75s, there's a 1 in 2 chance of those people being admitted to hospital. I think we all know that's a big issue and one that we need to think of solutions for. Next slide, please. This is where our patients come from. So you can see the percentage of overall patients against a backdrop of an increasing number of patients. Percentage being referred by general practitioners was decreasing. A very small percentage referred by GP out of our services was increasing. And the number of self-referrals was also increasing. Next slide, please. The last one was admissions. Next slide, please. That's so very much similar to the last slide. So, this is my third last slide in this opening session. And really, the ED has to be the hot part of an integrated unscheduled care system. But it has to be just the hot part. It can't be the miscellaneous filing bin. It can't be the route of access to all things that lack of capacity drive patients historically towards emergency departments because of the new requirement for physical distancing. Next slide, please, Erica. So, as I said at the start of this talk, and this is the second last slide of this section, we went to the trouble of creating this poster to explain to patients way back before COVID what is likely to happen to you when you come to an emergency department. You can see there's check-in, there's assessment, there's treatment, and there's outcome. We had it checked out by plain English. We had it checked out by various different people that this would be clear to patients presenting in distress as to what is likely to happen to them. You can see registration there, and then you can see triage. The Manchester triage system, as a lot of us know, is a very well validated system for defining the degree of urgency of any particular presentation, not necessarily the degree of sickness, but the degree of urgency with which a clinical intervention will make a difference to the reason for them presenting. 5 categories. One is immediate, in other words, drop everything you're doing and go straight to that patient. 2 is very urgent, time-critical conditions like ST segment elevation, MI, acute severe asthma, that you need to go to that patient as the next patient. And those 2 groups historically comprise about 20 to early high 20% of attendances at emergency departments. In other words, they're not most of the patients, but they are in the needles in the haystack that need to be picked out quickly. Which means that the other 3 categories, urgent, not very urgent, and non-urgent, the effective triage for them was to put them into one of those categories and make them wait longer than they would have waited had they just been seen in order of time of arrival. We used to be able to do that as a way of dealing with a system where the patient demand outstripped the capacity of the system to deal with it. I suspect we can do that no longer. Last slide, please. Bang, along came COVID. And all of a sudden, we were very concerned that we were going to be overwhelmed. We were very concerned about nosocomial infection. And we came up with this screening process as a recommendation to the system. It's on Dr. Stevens' library. That when somebody presents during COVID, a very quick pre-triage assessment and screening would happen. If there was a suspicion that they may be attending because of COVID infection, they went into the left hand, in other words, the red, yellow, and green columns. Green were the group who may well have had COVID, but we should have turned them around and sent them home rather than admitting them into the hospital properly. Red were the ones who might need absolute immediate oxygen supplementation techniques, including intubation, or maybe if we were being overwhelmed, resuscitation would be futile. So that's how we divided the COVID stream. And then on the right-hand side, we have to remember the non-COVID-19 related ED treatment stream. And there was a lot of stepping up to the plate amongst, it was a great Dunkirk spirit, as I would call it, amongst other hospital specialties helping us out at the time to deal with our traditional ED treatment streams, or to deal with that yellow stream there, which would be the patients who are likely to need admission with COVID but not need aggressive resuscitation. So I'm going to let our other speakers speak now, starting with Robert Morton now in a moment. And then just at the end, I'm going to come back with that slide and move on to what the future might look like. Thank you. Is Robert there?
Hi, Jerry.
Hi, Robert. Thanks
for
coming.
Good stuff. You can hear me okay?
Yeah.
Perfect. Jerry, thanks very much for inviting me to speak. Just looking at the list of names on the right-hand side, it strikes me that I've had the good fortune over 27 years in a previous life to sit and listen in a classroom with many of the people on the right-hand side. So it feels like very much a privilege to speak to you this evening on a topic I've been involved in for about a year and a half. But just Erica may have a slide to put up, and it's only a slide as a prompt. It's nothing exciting, but really what I was going to do was just talk you through some thoughts under those topics, basically. And to some extent, I'm conscious that I'm telling you what you already know, but really what I'm hoping to do is perhaps just give you a flare of what the HSE at large, as it were, understands to be the current challenges and the context as it's changing, and basically what we're trying to do to mitigate some of the risks that are emerging. I suppose in terms of the challenges faced by ED, Jerry, you mentioned the risk of the ever-present risk of infection to staff as well as patients, and we're conscious of that and what that means in terms of physical spacing. But I suppose above all, what we're seeing is the relentless rise in demand for both attendance and admission through ED. And at this stage, I guess, from an unscheduled care pathway, it's actually refreshing to hear you talk about unscheduled care as starting elsewhere. There is still a kind of a narrative within the HSE that we continue to talk about unscheduled care like it's some sort of an acute hospital problem, and even probably more a narrower perspective where we see ED as the problem. And I guess what we know, and perhaps what we've learned from the recent review of looking at a number of sites across Ireland in the last 12 months or so, is that ED tends to be, I suppose, a consequence. The challenges in ED tend to be a consequence of that demand, but also the fact that unscheduled and scheduled care compete for a space that's just simply too small and not big enough to cater for all demands. And just maybe to articulate that in numbers, if we look at the service plan, for example, for this year, which clearly has been paused, for the want of a better word, but we know that about 600,000 or 625,000 episodes of inpatient care should be happening in the system this year. But if you basically take maternity away from that figure, which is about 108,000, you know, you're looking at just over 500,000. And basically within that, we expect to do 91,000 elective activities. And I might just come back to that figure. So maybe just hold that figure of 91,000 in your mind. But I guess the consequences that both people working in ED and people attending ED faces the risks from COVID and other healthcare infections, the challenge now of working in PPE, the productivity impact that has, and the fact that EDs remain overcrowded. And that's a challenge to try and change that, you know. But above all, I think we're dealing with this perverse measurement of what happens in ED through Trollegar, and that's something that I might just touch on as well. In terms of the changing operational context, we know that unscheduled care demand is returning to normal. And right now there is tremendous political pressure to scale up elective activity. And I think we can already see in the last 2 weeks, 2 to 3 weeks, where that elective activity, that 91,000 patients are trying to get some access into the system and what that's beginning to do, and where we can start to see some of that pressure backing up in the system into the emergency departments. We know that there's a productivity impact right throughout the hospitals. You've touched, Jerry, on the potential impact of social distancing, and I guess at this stage, pre-COVID, we had about 11,300 or thereabouts inpatient beds, depending on the day of the week. And post-COVID, with the scale up in terms of surge, that bed number has gotten up to north of 13,000. And we've obviously seen a doubling of ICU capacity, but some of that has consumed some of the inpatient capacity as part of that scaling up. But a lot of that bed capacity is temporary in nature. And again, I'm just going to come back to that. But certainly, if we look at the impact of social distancing, if it is 2 meters, and at the moment there's no definitive guidance around that, but if it is 2 meters, and we're currently interpreting it to mean 2 meters between patients as distinct from 2 meters between beds, there is the potential for up to 20 to 25% loss of inpatient bed capacity. And if I just single out the UL Hospital Group as one that's done quite a reasonably detailed piece of work on this week, because Paul Reid has asked for an impact assessment, which is currently underway. They have estimated that they will lose 130 beds across their group. Now, in a system that has a deficit of 156 beds to start with, that's bordering on catastrophic unless there are a range of other things that are done to begin to mitigate that challenge. Patient flow, we know, is critical in terms of unscheduled care. And if we look at one of our key dependencies, the private nursing home sector, it has effectively imploded. So that dependency, something different needs to be done to mitigate that, because we very much depend on that. And we saw delayed transfers of care, for example, rise by 200 in the space of about 3 to 4 weeks. That was the dramatic effect. But we do know when that egress is available, and we know when we can put money to it, it does actually work. And discharge management obviously is a key feature of creating capacity in the system. Staffing, I guess, has been another challenge, because obviously people are impacted either by sickness, absence, or by childcare, and obviously that issue isn't self-resolving very quickly. And then the termination of the private hospital agreement is part of the current context, I guess, as well, and we know that there's work being done around that. But in all of that chaos, there are some clear messages coming from the HSE, which are probably very welcome and haven't been spoken as firmly perhaps as they could have been in the past. And probably one of those is, we obviously know that COVID-19 is here to stay, but one of those basically is that we must get to a position where bed occupancy is maintained at 80%. Now that's a huge challenge, bearing in mind that today we're already at 95% today. And that means that there are very clear decisions that need to be taken. For the first time in the 18 months or so that I've been in this particular role working in acute operations, I've heard somebody say publicly and put it on paper that we now are adopting a zero tolerance approach to ED trolleys and ward trolleys. So even just the intimation, I guess the ambition itself is important as a starting point, but I'm mindful that you guys have been working in this sector for a long, long time and probably have heard those sorts of ambitions. But frankly, I've heard it and seen it in a way that is resonating across the corporate, political and operational system. So there's a synergy in the message, I guess, which perhaps there hasn't been in the past. And there's very clear narrative around the fact that we need to adopt the lessons from last winter. So the last 2 winters, there was a lot of learning, a lot of trials, for example, of different things and whether or not we can scale those up, and particularly from COVID-19. But above all, there is a very, very clear message emerging from the HSE, which is that the solution must be one of capacity. And when we talk about capacity, it is, yes, of course, it's new capacity, but it's also effective discharge management. And colleagues, for example, from the medicine environment, so the acute medicine environment, have a really important role to play in becoming embroiled in the daily grind of bed management, which today in most hospitals is the domain of bed management and nursing leadership, but there is a strong role to play. And if I give you a very, very brief analogy, if I go to a hotel, and I'm not by any means making a comparison between a hospital and a hotel, but if I do go to a hotel, I expect the people leaving the hotel to check out early, and I expect to join later in the day to give people an opportunity to do what needs to be done. And hospitals, we tend to do the opposite. If you look at the attendance patterns, people tend to build up the attendance patterns relatively early in the day. If you look at the departure pattern, it tends to be relatively late in the day. So somehow we need to figure out a way to kind of reverse those two dynamics, I guess. But clearly discharge management, reducing demand obviously is a critical area, and providing some streaming options, more streaming options, for example, and giving more options to your emergency departments. How can you accelerate or have more options for the three out of every 4 patients under 75 that you see, and in general terms you make a decision to discharge. So bearing all of that in mind, the current HSE focus from a planning and operations perspective really is hospital groups right now have been asked to focus in particular on initiatives to reduce demand, and some of that also stretches into the elective environment. And Vida and I are just becoming involved in a piece of work around the planning for resumption of services, which already many services have already resumed. But some of it is about giving permission, for the want of a better word, or air cover perhaps, to actually not continuing or discontinuing or not scaling up some elective services to the scale at which they've previously been run. Some of it is about working in tandem with community, and Jerry had some really interesting statistics there about the over 75s and the 1 and 2 likelihood of admission, and when they are admitted, then they're twice as likely, their length of stay is likely to be twice as long. So in terms of the amount of resource that they need, and we know that many of those patients turn up in hospital because they are older but frail, but also are vulnerable, and perhaps there may be a different option if there were more supports available in the community. So community have been asked to look at the community assessment hubs, which were set up for COVID-19, but to see how can they be re-engineered to basically focus not just on COVID-19, the second wave if it happens, and I guess it probably will, but more importantly, flu and respiratory illness, and with a particular focus on the over 75s. And how can you then build some community supports around that to reduce the need for some of those patients to attend the emergency department? And I say that in numbers terms, but recognizing that from a real clinical and patient perspective, many patients need to attend, even if they don't need to be admitted. There is a clear piece of work, and a submission has already been made to the Department of Health looking for a sustainable increase in intensive care capacity. And I'm also involved in a piece of work around planning for inpatient capacity and putting forward a fairly detailed submission. And that work is very much at an advanced stage. And effectively, it's got 3 or 4 parts to it. Many colleagues may know about the NTPF winter initiative we had, where we've got 220 beds supported across the country. That funding is due to expire in June because it was a winter initiative, which we got it extended because of COVID. We're now asking for those 220 beds to be maintained in the system, recognizing that we've now got to mitigate the social impact piece. The temporary beds, of which there were 324 opened with COVID-19 money, again, 6 months money, we're asking for those beds to be opened on a long-term sustainable basis. We're looking to the capital plan to see what's in the capital plan that can be accelerated. So again, if I give you examples, University Hospital Waterford, the Dunmore wing, basically obviously was accelerated. The 40 beds in South Tipperary were accelerated for opening, and the 60-bed unit in Limerick, for example, and then there was 24 or 27 beds in Our Lady of Lourdes Drogheda. So looking to the capital plan to see what's out there, what's in development, what can be accelerated. And then the final piece of that is looking retrospectively at the capacity review from 2018 to say, right, where do we actually need the beds? When all of that work is done, where do we actually still need beds, and how can we prioritize modular builds or whatever we can do? And much of that submission is about informing the incoming government or the programme for government, and effectively positioning ourselves to say, look, at winter is 6 months away, COVID-19 is still at our ankles, we're still facing huge challenges. If we're really serious about a zero tolerance to ED and decompressing the pressure in ED and offering patients and staff a different option, then here's the bill. And that sounds very blunt, but that's kind of where we are. Some of the other stuff we're doing, I think, which hopefully will be of benefit to supporting some flow from EDs, is actually developing an intermediate care capacity plan. And this is very much a step up and a step down model. So, for example, patients who would normally be referred from primary care can arguably be referred into a subacute or an intermediate care environment, clinically governed by the acute hospital system. and also perhaps streaming from the ED back into that environment, but then also stepping down patients into that environment who would otherwise be waiting for fair deal or access to home support packages. We know that obviously work is ongoing or will be ongoing with the private hospital system to look at elective activity, because I refer to decisions that are required. In real terms, we are going to have to look seriously at, dare I say it, you know, converting many of our public hospitals into unscheduled care only hospitals if we are to be serious about decompressing some of the pressure. And that's easier said than done, but at least that's a line of direction that's being pursued by the HSE at the moment. And then we're working with the NTPF to look at how can we support more GPs to have more diagnostic access. And we had a scheme over winter called the EDAN scheme, which proved to be quite effective. And we've still got that running up until October. And then probably just the final thing that we're looking at is the crisis response teams that were developed by the CHOs to basically respond to and support private nursing homes. So we're looking at re-engineering those homes to basically be more effective and support discharge management, to create more of a pulling effect from the acute system rather than the traditional model of the acute system pushing patients into the community. So just finally, maybe how do we propose to take this forward? Well, as I mentioned, Colm Henry and Anne O'Connor are basically leading a piece of work around the planning and resumption for services. So we're hoping to capture all of these pieces of work into a single plan and a single submission to government and to the incoming minister. Ideally, those pieces of work would not be informed by people like me, it would actually be informed by yourselves. So recommendations through the clinical programs. And I know Emily is online, and Emily, I've seen the recommendations from the IAEM and they are very, very welcome. But I think what we want is the recommendations from all the programs to inform as much of the work. So effectively what we're putting forward is clinically informed, clinically supported, and eventually clinically led. And then just the final piece to say is that in terms of real hard cash, because that's what it's going to boil down to, it's going to boil down to real hard cash. Our more immediate action that we're taking at the moment is the winter planning process, and that's already started. So that those conversations with the Department of Health have happened. I speak with them every second Monday, and it's pretty much about influencing and about informing our colleagues in the Department of Health what we think and what we think won't work, and what we think the new incoming government need to see as an immediate priority for funding. So Jerry, I'm just going to stop it there. I really apologize.
Yeah, that's great, Robert. Thank you very much for your time, your presence, and your insight. I think we know that capacity is an issue, and finally we're acknowledging it. Both capacity within hospitals, but other what we might call safe discharge options into the community. And I think we probably return to some of those, so that the 3 out of 4 that we discharge might become 3.5 out of 4. It's all about safe discharge. So thank you so much, Robert. Can I just remind people, we have a list of questions already sent in, but there's room for plenty more questions if people want to send them in, and I might address them later on, depending. I might ask the questions of the panel, depending on how we get on. John Ryan, are you there?
Yeah, indeed, and that's
someone needs to go on mute.
All right, still, but it's good to have her here.
Okay.
So, shall I crack on?
Yeah, please do. Thanks very much.
You told me 6 minutes, and Rob clearly stole 2 of those, so I'll race through this. And thanks, Erica, for putting this up. So, look, for those of you who don't know me, I work in St. Vincent's University Hospital, which is a teaching hospital inside Dublin. University Teaching Hospital. We see about 60,000 adults, so we see over the age of 40. So any slides I'm going to show you that pertain to content pertains really only to people over the age of 14. Next slide. So this one is where we were last year, and the peaks are Mondays and the troughs are Saturdays and Sundays, and it was a steady as she goes, and that was from March. Sorry, that's not March to June, but that's from March of last year to June of last year to March of this year. So next slide, Erica. And Robert spoke about scheduled care and unscheduled care, and just to show you that really unscheduled care is schedulable, and it's very predictable when people are going to arrive and attend. And this was 3 months in 2019. and it was all very predictable, really, in terms of when people were going to attend. Go ahead, Erica. You know, in April of 2019, last year, we had gamesmanships going on, and we had the big trolley waits, and we had lots of crowding and patients staying on trolleys. And this is an admissions by the number of admissions throughout the month of April. And you see people were allowed billed throughout the night, and then suddenly before the 8 o'clock in the morning, they all went to the wards. And you can see a second peak there over the right after the evening handover, when people were building throughout the day. And that was the case, and that was where we were last year, with 2 spikes in terms of when people were admitted, and building up to both of those, and not very productive. Next slide. This is a slide of patients being discharged in under 6 hours, and it goes over 2 years, right up to the time of COVID. So, and it's 5, sorry for the clutter, it's 5 academic teaching hospitals in Dublin. And you can see the one at the top in blue, in Vincent's blue, was having a really good time around 2018. But there was a steady decline in our performance over the last 2 years, up until the time of COVID, in that we weren't able to get as many patients out in under 6 hours as we would have wished to. And that was heavily driven by crowding. Just next slide. And I'll come back and show you what the impact of that has been. So then, boom, COVID arrives in March of this year. And we built up a tent, and we prepared for the disasters, and tried to recruit and harness the numbers of intensive care beds. David Menzies took a great lead, and over a weekend, with great collegiality, we split, as was the recommendation, into a non-COVID emergency department and a COVID emergency department. Next slide. And this was comparing from the beginning of March there through to April. The blue line is last year's attendances in the emergency department. And so we had a big drop off in attendances, up to, we were looking at work around 60% of our work, and that all came all of a sudden. And then if you go to the next slide, just to add on to that, that takes us up to where we are at the moment. The patients started to come back. So the yellow line is this year. The blue line there superimposed was last year, and that was the attendances last year. And this was the same 3 months from March to June now. And so the numbers have started to return, and they've started to come back to us since the beginning of May. And now we're seeing really big high peaks. Yesterday is not on that graph there, because I did that graph up to the weekend, but we had 211 patients yesterday over the age of 14. Go ahead. So this is just the same slide, and to show you that on the bottom our attendances to our, and how we broke them up into COVID and non-COVID. So the gray line, as you can see that, and there's a slope line you can see was the number of people attending COVID, and so people that were streamed into COVID. The blue line on the bottom is the number of COVID admissions. So we've been kind of going around about 40 to 50 patients a day streaming through our COVID suspicious area, and of those, about half and a little over that in the early days were being admitted either as COVID patients or as patients under investigation. More latterly, we've had a rapid diagnostic test, as where we could get tests turned around within an hour, but realistically within 3 to 4 hours. And so we've been able to move those patients that are non-COVID positive to non-COVID wards. But you can see that the stream of admissions has continued to increase. The slope there on the brown graph has increased, not surprisingly, as our number of patients the attendances has increased. So has the number of admissions proportionally increased. Go ahead. So that's just taking out that blue line of last year and giving you a greater clearance of a greater picture of how we've had this growth over the last 3 months. Everybody's scared away mid-March, hitting our peak COVID, into mid-April in Ireland, and then a gradual confidence and return of patients. But us having to live with two emergency departments running in tandem effectively, a COVID emergency department and a non-COVID emergency department. And we had good collegiality and buy-in from our ID and our respiratory physicians and medical people. We had extra docs provided to the non-COVID, to the COVID side of the emergency department, and a few extra, but not quite so many proportionately, to the non-COVID side under the scheme of coming back to Help Ireland. Go ahead. So this was the impact then again. That's the graph I showed you earlier of the 5 Dublin academic teaching hospitals, where the one on the top there. So we're getting more patients out than other emergency departments, and our performance was dropping off over the last 6-9 months. Then COVID came, and boom, we had a great improvement, and we were getting 95% of people that were going home out of the department in under 6 hours. Just watch that slope there over to the right. It started to go down again. So over the last couple of weeks, we've not been able to get as many patients out in under 6 hours as we had right at the peak of COVID. So go ahead. This is just to show you where our patients are coming from a little bit and what's happened. So the blue line again is 2019 and the volume of GP referrals that we were getting, patients coming in the month of March, April and May. And so this year, when COVID broke, albeit only half of March, our GPs effectively stopped sending us patients. And so the only patients we were getting were 999 patients and some walk-ins, but we were getting very little GPs. And then in April, they started coming back. And now in May, they are coming back with a vengeance. And so we're 20% more GP referrals now than we had this time last year. And many of these, as other physicians will know, are from GP practices with from non-face-to-face presentations, patients coming with their GP referral letter on their phone, having been emailed to them. Go ahead, next slide. And our admissions, this was the admissions for the month of March, April and May for last year, and the impact that COVID has had on our admission rate this year. So admissions were down in March, not surprisingly, because our overall attendances were down. But in April, our admissions started to go up, and now our admissions are up again. We lost our clinical decision unit and our chest pain evaluation unit as a part of having to give it over functionally because we were doing other things, and geographically and the footfall, we had to lose it into our COVID ED. So we stopped running a clinical decision unit and chest pain evaluation unit. We were putting 6,000 patients a year through those two, and so those patients are now being admitted under the care of the physicians, and length of stay has probably gone up in that cohort of patients. Next slide. And of course, this is HBSC guidelines, and effectively, if you read it, says we have to keep going with a COVID stream and a non-COVID stream, and we're aware that in places separate COVID areas are being wound back, but we know that the community spread is less, and certainly it's great that the amount of COVID is less, and our curve has gone down, and we're flattening it out. I haven't heard what it is for today, but it was down to, in terms of new cases, pretty low yesterday. But nevertheless, the patients with presenting symptoms compatible with COVID continue to come. So the HBSC guidelines for that is, patients with new respiratory complaints or deteriorating respiratory complaints, they're going to keep coming, and they therefore, while COVID exists, have to be treated as potential COVID. So for the moment, we're still running with our COVID stream and our non-COVID stream, albeit we're not admitting virtually anybody with COVID anymore. But this is something, I guess, it's version 15 at the moment, and it's probably something that will change again. But it is driving our streaming process within the emergency department at the moment. And I think the next slide is the last slide, which really is just a summary and just, when it happened in March, we had to split very quickly the department into a COVID ED and a non-COVID ED, sacrificing our clinical decision unit and our care screen evaluation unit, and providing consultant cover 12 hours a day, 7 days a week on the COVID side and on the non-COVID side by emergency physicians with input from our RESP and general internal medicine and ID people on the COVID side. So there was great corporate collegiality, and it all happened very quickly, spearheaded, as I said, by David and my other consultant colleagues. So the consultant hours increased, and we haven't had any annual leave since, nor have really any of our trainees. Our numbers initially dropped off to 60% of normal activity, and as you've seen from the data, our crowding disappeared and we functioned much better. Relaxation phase 1 came and people returned, and the GP referrals returned and the crowding has returned. And so this morning we had 17 patients waiting admission, with 28 patients in the department at 8 a.m. And so we're at risk, and we fear that the new normal that people talk about may in fact be worse than the old normal. And that's the challenge for Robert to work with the others, and for Vida, who's coming on to bring solutions that will wind us back into where we were without the COVID in March, April, where we worked and effectively, efficiently, had no crowding and in a safe environment. And so I think that's my 6 or 7 minutes.
Thanks very much, John. Very rich data, crisply presented. I know you promised me that you wouldn't go on about Vincent's being the best emergency department in Dublin. So you just showed it on a slide instead. But thank you very much. Is it Vincent's Blue or Leinster Blue?
Well, there's a huge collegiality, as you know, an overlap between the both. Right. And we wear the blue of Leinster, and Leinster wear the blue of Vincent.
Yeah. Thanks, John. That was great. Ash Butt, if he's ready, I'm going to move. As you remember, I was saying there's a compare and contrast issue between the capacity within Vincent's, despite the slightly bum note that you ended on, John. It's sorry to see the crowding coming back, but it is reality. And they're the big challenges, and that's why we're having this meeting. I'm going to keep moving right on because we are running late. Ash is a consultant in emergency medicine in Cavan General Hospital. Worked a very tight roster, I know that, and I've asked him to speak to the title that you see in front of you there. Thanks very much, Ash.
Thanks very much, Jerry. As Jerry mentioned, I'm a consultant in emergency medicine in Cavan General Hospital. Next slide, please. So we're a Model 3 hospital. We have a 24/7 emergency department. We have acute medicine, acute surgery, critical care, pediatrics, and obstetrics and gynecology departments here. Next slide, please. In our emergency department, traditionally and historically, actually, we have 10 clinical spaces only, and very tight space. We are based in an old pharmacy building, basically. Next, please. Our total attendances were approximately 40,000 between the injury unit in Monaghan and of Cavan General Hospital last year. Our emergency department attendance were around about 35,000 approximately last year for Cavan Emergency Department. Next, please. We have total 267 beds in the hospital. Next, please. We met quite early because we knew we had the physical and staffing constraints in our hospital. So we met in January, multidisciplinary treatment. We decided to take mitigation against those potential issues that would arise. Next, please. Clinical space in the emergency department. Next, please. That was the biggest problem we have. And next, please. We have only 183 square meter. Next, please. Clinical space in the emergency department. And it is impossible, it was impossible for us even in the pre-COVID era to manage our workload with those 10 clinical spaces, 183 square meter. Next, please. So the next, please. Yeah. So the first decision was made by the management and the committee that we need to improve the space. We have only one single resuscitation bay. You can see how small that is. Next, please. And no isolation rooms in the emergency department. Next, please. So we added next, please. We added approximately 322 square meter well-needed space into the clinical space, which already existed. Next, please. That gave us approximately 505 square meter clinical space. We had a triage tent, which was erected within 1 day outside the emergency department. Next, please. And we had a waiting area outside that triage tent. That's a porta cabin. Thank you. Next, please. We expanded into the outpatient waiting room and into the AMAU space. So the AMAU area was designated as the respiratory side of the emergency department, and the rest of the patients were on the non-respiratory side. Next, please. Next, please. Staffing was our major issue. Again, in the emergency department, we had only 16 NCHDs, and Department of Medicine had 46 NCHDs only, and nursing and midwifery, they had 389 staff in the hospital, as I believe. Next, please. So we decided about redeployment of the staff. Lots of nursing staff who had experience of working in the intensive care unit were called back from the community. Physiotherapists were called back from the community. Staff from the other departments, for example, endoscopy, outpatient, those nursing staff were deployed in other areas. We were lucky to have paramedical staff from Code Blue who helped us out as well. Thank you. Next, please. Critical care point of view, we had 3.5 consultants in the hospital. We have 5 critical care beds, and we had 2 negative pressure rooms in the whole hospital. Next, please. IPC team started training staff, and the first training session was on 5th of February, I believe. And between the 2 hospitals, they trained 1,500 staff within a few weeks. Next, please. We decided early on that we want to do the testing locally. And initially, we were sending the samples to NVRL, but when the public the public testing started, NVRL was swamped with the samples. So we had negotiated with the Beaumont and Runda Hospital to do some of our swabs, but local testing started in the 2nd or 3rd week of April. And since then, we have 24/7 testing and 4-hour turnaround time. Next, please. The protocol was changing nearly every day. We have 16 version 16 now, and every version had, different versions, 6.1, 6.2, 6.3. So it was difficult to communicate that with staff. So we had WhatsApp group and Skype sessions for updating the staff about the new protocols. Next, please. So the best thing which we did was we had the 15-hour handover meetings in the hospital. 4:15 every day. We decided about in these meetings, we have the medical consultants, critical care team. We did that online, obviously. We didn't sit face to face. And the ED team, we decided about the ceiling of care about certain patients, their resuscitation status, and decided about which patients care needs to be escalated to the intensive care unit. Next, please. Next, please. And then the calamity struck. We had outbreaks in our hospital between staff and the patients, unfortunately. The first spike was on 30th of March, and the second spike was, next, please, on 6th of April, 2020. So 26 staff members were infected on that day. Next, please. Next, please. So 83 of those staff members were nursing staff. This is up to the 15th of April now. Next, please. 30 of them were medical staff. Next, please. And 31 of the HCA were infected. Next, please. this thing hit us really hard then. We were in the media. Next, please. The morale of the staff was down. Next, please. We didn't know what hit us. Our Department of Medicine was basically banjaxed. We didn't have any staff left. Out of 46 medical NCHDs, next please. Out of 46 medical NCHDs, 20 were COVID was detective. 15 were quarantined because they were the contacts. So only 11 NCHDs were left. So we found the benefit of being in the group. Beaumont Hospital luckily sent us staff, few of the NCHDs. We really thought of reloading 220 again, basically. Next, please. What we did then was we had outbreak meetings. We decided to update our guidelines for the PPE. And we ahead of the national guidelines on approximately 7th of April, we had the guidelines, as I believe, and 7th of April. So the national guidelines changed on 22nd of April. We had decided to divide the hospital in different zones, red zone, orange zone, and green zone. We had ward-based teams then. We had very low threshold of doing the testing. Next, please. Next, please. Next, please. All those measures, they helped us out. So by 5th or 6th of June, we had 178 staff members who were COVID positive. Next, please. And 183 of the patients were positive. Next, please. And total positive patients in our hospital were 361. Since we took those measures, only 20 more healthcare workers were positive for COVID-19, and none of them were doctors. Next, please. This slide, the different shades of blue, that tells us the story of Cavan. In Cavan County, we had the highest number of incidents of COVID-19 per 100,000 population. Next, please. So the top of the country, 112.1, and that was our dilemma. That's why we were inundated more than likely. Thank you. Next, please. We did have minor issues with the tertiary center referrals, where the different teams were asking us to do CT scans and MRIs and biopsies through emergency department before the patient would be accepted. Next, please. I think what we need is for emergency department here, appropriate and adequate space, appropriate and adequate isolation facilities, appropriate staffing levels. We need to bump up the hospital bed capacity, and we need to have appropriate pathways. Not everybody needs to come through the ED to get their destination wherever they need to be admitted. Next, please. So the right patient should be seen at the right time by the right clinician. Emergency department shouldn't be the only pathway. Thank you. Next, please. Thank you.
Thanks, Jerry. Thank you so much for what was absolutely the intended contrast in terms of what you're doing. And I think those last couple of slides you showed are very rich in terms of what needs to change. So we'll come back to that because I see questions coming in and I need us to keep moving. So thank you so much, Ash. We'll move on now to the president of the Irish Association of Emergency Medicine, Dr. Emily O'Connor, who's also a consultant in emergency medicine in Connolly. The IAEM has recently launched some recommendations, which Robert Morton has already referred to as being very sensible, and Emily's now going to speak to them. Thank you, Emily.
Thanks, Jerry. And for the record, the colour that Robert, John, Ash and myself are wearing is IAEM blue, nothing to do with Leinster Rugby or St. Vincent. So just to get that on the record. So this is the Irish Association of Emergency Medicine is the representative group for doctors in emergency medicine in Ireland. And we're here to set standards for patient care, for patients attending the emergency department. That's one of our core roles. So this is this last few months, what we have decided after the experience of coming through the last few months is that we want to reset care in Ireland's emergency departments. So this is what this talk is about. It doesn't include any data. It's purely an overview with specialty recommendations. Next slide. So what did IAEM do for our members during COVID? Well, first and foremost, we started a live forum for consultants in emergency medicine from all around the country, and we met every 48 hours. That was probably most contact we've ever had with each other, and it was really critical. As everyone remembers, things were changing very quickly. We were able to link with each other. We were able to share videos of good practice. We were able to share problems. And I think what really came across more so than ever was the variability in emergency departments, not because of clinical practice, but because of infrastructure and management style responses to what was a crisis for emergency medicine. We also set up group communications, once again sharing good practice, tips, and thanks to everyone who put together efforts that really helped out people in other departments. We have and still have over 100 participants, which, given that we only just have over 100 consultants in emergency medicine in Ireland, has been really good buy-in. I also, on behalf of IAEM, I'm on the Council of the Royal College of Emergency Medicine in the UK. The UK emergency medicine experienced and experiences many of the problems that we have, and I was on that clinical leaders forum, and we were able to track the UK experience. We were able to track what they found worked and what didn't, and we have been able to use some of their standards and recommendations. So all our guidelines are based on international good practice. Just to fly our flag, we had one of our own presented the new developments in using ultrasound for the diagnosis of lung ultrasound for the diagnosis of COVID-19, our own Cian McDermott. And it was really nice to see what's best practice in Irish emergency medicine being rolled out to our international colleagues as standard setting. I was also invited to partake in the Department of Health Public Health Medical Leaders Forum, and it was an opportunity to find out what I suppose the difficulties and priorities of all the different colleges around the country was. And this was using all that experience from numerous different formats. We have set some standards and put together some expert guidelines and these recommendations. Next slide. This was one of our expert guidelines. This was put together and by our members. What came through in those first few critical weeks of responding to the respiratory emergencies in our emergency departments was that the capabilities and expertise and equipment was different all across the country. And I suppose I know people think that ICU guidance or anaesthetic guidance is always applicable to respiratory or airway emergencies in the emergency department, but emergency medicine offers different challenges, and we put together this document which described how we would escalate respiratory support for patients coming into our emergency department, the oxygen requirements that were needed, the types of equipment that were needed, and the expertise and PPE that was needed. So this has been sent on to Jerry and hopefully to Davida also to go up on the HSE guidelines. And thanks to the names are listed there. Thanks to our members that contributed to this. IAEM also contributed to the streaming document that Jerry put together. That's now up on the HSE website. Next slide. What came through from the experience from all around the country through COVID? Well, there was good and there was bad experiences. Critically, every ED in the country stayed open, receiving all comers throughout this. And as you can see, some places, including Cavan, particularly Cavan, that was a heroic effort. And I really think it pays tribute to what we're here for, the fact that we stayed open despite the difficulties. There were good things. Attendance is reduced. And in case there's any misunderstanding, if attendances hadn't reduced during the early weeks of COVID-19, emergency departments would not have coped in Ireland. We simply do not have the capacity. So we're really, really thankful for the public in following the public health guidelines, and to patients for staying away, because without that, we would not have coped. Guidelines came down, long overdue guidance came down very quickly from the coroner about changes in practice, and the ethical guideline that came down through the Medical Leaders Forum was long overdue and very welcome. There was no en masse decanting from nursing homes. We were very concerned about this, and we knew that there were several nursing homes around every department in the country that was really struggling. Lots of patients were transferred from nursing homes, but there was no en masse decant, and we were very grateful for that. Huge EM expertise in airway and respiratory support came into play, and we were able to put that together both on the ground, managing patients, and in the expert guidelines I referred to. We proved ourselves to be, as a specialty, dynamic and adaptable. As you can see from both John and Ash's presentations, things changed every single shift, and staff but just stepped in and adapted to it. And unlike other specialties or other services, emergency medicine doesn't get a run-in time to adapt changes. There's no filter between the population, our communities and us. So we need to adapt immediately. And one of the frustrating problems was the gap I think, in HSE local management responding to changes that were occurring both at professional level and at HSE Central. That gap time is very difficult for emergency departments to cope with. We had a member on the expert advisory group who was able to keep us up to date with guideline changes, thanks to Ger O'Connor from the Matter for doing that. Many specialties stepped forward, and by being forward in care, they involved themselves in care earlier in the patient's journey. And thanks to all our physician, ID, anaesthetic, ICU colleagues who did this. And we also had some good practices about being less dependent on handwritten records. There was a lot of bad stuff too. ED infrastructure in many places simply wasn't there. There's no redundancy built into any emergency department or any emergency medicine service. And therefore, when staff went down and when space became difficult and when things slowed down because of PPE, it was very difficult. There was variable listening to EM expertise around the country. In some places, emergency medicine were able to get the message through very quickly to their management teams. And in some places, we weren't listened to. That has to stop. I've already flagged the gap between HSE Central and HSE local management. That gap is too big and too slow. There was changes in how general practice was delivered. John referred to the consultations going online and referrals to emergency departments without face-to-face consultation. This has an impact on ED referrals, and we need to measure that and not ignore it. The lack of ED coding is a problem, is that in that we continue to struggle with measuring the work done in emergency departments, whereas work done on wards with hype coding and the inputs into the case mix data and is therefore better measured. Some pathways within the hospital broke down, and many smaller emergency departments had difficulties with some of the tertiary the transfers out of hospital, and the tertiary referral pathways broke down. And we all know that there were lots of white elephants funded, and we all know what they were. It's not that they were a mistake to set up, but we have to, I suppose, realise that we should learn from that. There was no white elephants, or there was no extra money put into emergency departments that wasn't used. So we need to remember that when we're funding things in the future. Next slide, please. So this was the start of our recommendations. This was the statement put out on the 12th of May about resetting care in Ireland's emergency department. It set out there are three main principles, which was that we must not be allowed become areas to develop clusters of nosocomial infection. COVID-19 isn't unique in its mode of transmission, and overcrowding in emergency departments has been tolerated for decades. And that can't be allowed to continue. Patients must feel safe and know that they're not going to be infected when they come to an emergency department. We must not be allowed to be overcrowded again. And thirdly, pathways to treat patients outside the hospital setting must be consolidated and developed so that patients don't have to be sent to the congregated setting of an emergency department just to access any care. Next slide. This was a real step in the right direction, thanks to Robert Morton. So this was a HSE Central stamp on one of those standards. And thank you to Robert, and thanks to Jerry for allowing me circulate this. So there's social distancing requirements which preclude toleration of overcrowding in an ED or indeed any healthcare setting. Thank you very much, Robert. It's really important that departments around the country get to see this written down as policy by the HSE so that we can bring it to our management teams. Zero tolerance of ED trolleys. Once again, we realise that's not what's happening on the front lines. We've seen the overcrowding figures again today, but thank you for writing it down. That's really what we need to empower our members to get it implemented locally. Next slide. So these are the IEM recommendations. So first of all, achieving our necessary acute hospital bed capacity. Hopefully I'm talking to converted on this. We all know about the bed capacity review. We didn't want the private bed capacity lost to the system. That's already happened. But what we're saying is that all beds currently under construction must be accelerated. All capacity that's been brought into the system must not be lost in these coming months. And any new builds planned must meet infectious disease standard and plan for adequate social distancing. Next slide, please. So once again, Ash mentioned this. This is the Sláinte Care heading. We couldn't agree more. Right patient, right time, right clinician, right care. We recommend that every patient, every citizen in the country is to be registered with a GP. Now, in some areas of the country, that might not be an issue, but I work in a department in West Dublin where we have many patients that aren't registered with a GP, either because they're new to the country or because they can't get access to a GP's list. The government can make this happen. Every patient needs to be registered with a GP. We want to support primary care in its decision making. We all repeatedly see referrals every day from primary care because a general practitioner can't access diagnostics or can't access anything, any way urgent assessment for their patient other than accessing and sending to the emergency department. Once again, GPs they need to know that they're now sending their patient with a non-urgent condition into the congregated setting of an emergency department. And that is now not without risk, particularly because of COVID-19. We support GPs in having access to alternatives. Emergency departments must no longer be a replacement or a surrogate for all the non-emergency outpatient and diagnostics services that we currently are used for. Only patients that need emergency medicine expertise should be sent to the emergency department. Alternative pathways should be identified for all lower acuity presentations. Research work in NHS England showed that the drop in attendances at emergency departments was much more in lower acuity groups than in high acuity groups. It's this lower acuity groups. We don't need all of those coming back to the emergency departments. There must be alternative pathways found for them. Next slide. Patients also need to know where to go for care. There's variable international experience with this. But at this stage, given how complex accessing care is, work needs to be put in assessing a national information helpline and a national information campaign, so patients don't arrive at our doors and register simply because they didn't know what their options were. There's been very good practice developed by the National Ambulance Service with its navigation hub, and they're already using clinical staff, senior nurses, to assess lower acuity ambulance calls with some success. So that is a really good example that we would like rolled out. And once again, patients should not be directed to the congregated setting of an emergency department simply because it's the open part of the system. Even registration in the emergency department is abused because it's available. So that type of behavior can no longer happen. So no other specialty can refer their patient to the emergency department simply to access another specialty or simply to use the registration part of the ED. Alternatives must be found. Next slide. So then once the patients have arrived at the emergency department, we must reduce the length of time they stay there. We all work in departments where on occasions patients are waiting 10 hours to see a clinician even before the decision making occurs. The HSE should implement its own targets for around patient experience time. 95% is the target. We as a country only hit about 60% of that. And admitted patients, it's much poorer than that. And we want the patient experience times to accurately reflect what actually happens to patients. Gaming of figures should not be allowed, and I can give you numerous examples of how figures are gained. Pre-hospital and ED triage processes, infection control methods should apply from the first patient contact. We all work in departments where infection control only seems to apply once the decision to admit has been made. All patients, both pre-hospital and at ED triage, can have are at risk of cross-infection, and therefore policies and standards around infection control and social distancing apply to all parts of the patient journey, including the waiting room. There's been experience around the country of small ED waiting rooms having 60 patients waiting in them, and that's happening all the time at the moment. What everybody is saying is, if we're not tolerating that in our supermarkets, why on earth are we tolerating it in ED waiting rooms? Next slide. Next slide, please. So clinicians from all specialties must become more involved in urgent and emergency care pathways so that early specialist opinions are available to patients when they need it. That's around when the medical team are on call. The consultant needs to be their only duty on the day, so that clinicians aren't trying to compete, but trying to provide on-take as well as outpatient care. All consultants on call, be they surgical, orthopedic, diagnostic, medical, that must be their only commitment. They can't simply be post-call ward rounds. The consultants need to be available for the acute take all the time. And this also is for patients, when patients are being accepted out by tertiary centres, that decision-making, small departments can't simply be put on hold waiting for tertiary specialties to decide whether to accept their patient or not. There must be automatic referral of patients as described in the trauma network document. Electronic records, endless time is wasted copying notes, writing letters. We can't go back to where we were before, and we must develop further a common electronic records, electronic identity numbers. And we also must work and develop very quickly activity-based funding so that emergency department work isn't invisible to the system. Next slide. Hospital management teams must establish the maximum acceptable occupancy in their ED as it is today. We heard Ash describe that his emergency department was 183 metres squared. Every management team should be expected to manage the actual physical space in their emergency department and the number of patients and staff that can be in that space at any given time. That must be implemented, and we must immediately then build on that capacity so that we can implement social distancing. Decision making in the ED must be adequately and efficiently resourced. And so laboratory and radiology results, they must be available to us within 2 hours from request. Laboratory turnarounds isn't as problematic as radiology, but all of us know that our patients have to compete with scheduled patients to get on emergency lists. And then oftentimes the delay to getting a report can be far more than even at the 6 hour, which is our target for getting patients out. That can no longer occur. And we all still have to resort to admitting patients to access emergency diagnostics. Once again, that must become unacceptable practice. Next slide. So that's how we're describing we reset care in Ireland's emergency departments. Like all other specialties, we know what our patients need. We need HSE centres to agree the IEM recommendations so that we can now then locally bring what are HSE standards of care to our local hospital management, and that we have then some, I suppose, support to implement those standards. Final slide, please. So COVID-19 will continue to be a huge challenge for Irish emergency medicine. That's because we have massive infrastructure and capacity problems that are long flagged and long standing for us. COVID-19 is proceeding from pandemic to endemic state. We know what emergency medicine needs to make it work. So what we're looking for is the powers that be to help us implement these recommendations. Thank you.
Thank you, Emily. Spoken from the heart as ever, and thank you for clearly laying out that which we need to do. We're way over time now. I'm hoping Vida Hamilton is still with us. Vida?
Yeah, I'm here. Can you hear me?
That's great. Yeah, thank you so much for making time to come here. Vida, as you all know, is first and foremost a consultant in intensive care in Waterford, but more importantly for us, she's money back. I mean, she's the National Clinical Advisory and Group Leader for Acute Operations, and is going to speak to some of the drivers for change in emergency departments in the COVID era. Thank you, Vida.
Thanks, Jerry. So look, I've titled this Emergency Departments in the COVID era, and I think it's really important that we're very consistent with our language. COVID hasn't gone away. It's not going to go away until we have a vaccine or an effective therapy where it will no longer be a problem. The lockdown measures have resulted in a flattening of the curve in a very effective way. However, with the reduction in lockdown restrictions, we can anticipate that we're going to get a resurgence of COVID cases. We don't know if there's a seasonal variation with COVID-19. Maybe there is, maybe there isn't. But what we do know is that it's infectious. We know that we have very little native immunity in the community, so it is freely available to spread, and we know it's a complex multi-system disease that's actually difficult to treat, and in the 20% of patients that are admitted to hospital, that their care needs are higher than our typical admission, unscheduled care admitted patients. So this is a complex demand. I do want to first and foremost acknowledge and recognise the work done by the emergency medicine physicians and their associated staff in delivering care in a prompt and an appropriate way during this COVID crisis. They very quickly adopted the parallel streaming at the front door that allowed separation of COVID from non-COVID cases, and they put in to place very prompt and effective infection prevention and control processes, and had very rigorous training of their own staff with PPE use. And I'd like to acknowledge the very effective work that was done. Some of it was facilitated by the fact that there was an ambulatory alternative to ED treatment for COVID-19 patients, and that was in order to avoid a preferential pathway to testing via the emergency department, that ambulatory cases would not be tested in the hospital emergency department, but rather discharged to assess via the GP and community herb, or in the first stages, the NAS services. So having a realistic and existing alternative to ED ambulatory care is a clearly a key enabler of attendance avoidance. Particularly in those early days when testing delays existed, having had a perceived shortcut pathway would have been disastrous for the emergency departments. I'll move to the next slide. The other thing that I think it's really important that we're consistent with our language is not if or potentially or possible that we'll have a second surge. We will have a second surge. The only question is, will that second surge just be in the winter months, or will we have a second surge in advance of the winter months, given that winter starts in October? Our parallel streaming during our winter surge will be not for COVID, non-COVID, it will be for infection presentation versus non-infection presentation, because clinically we cannot distinguish between RSV, metapneumovirus, influenza, or even norovirus from COVID-19, because the presentations for COVID-19 are so variable. Similarly, many bacterial infections and sepsis presentations are indistinguishable clinically from COVID-19. So we're going to be relying on really good infection prevention control practices enabled by hand washing and masking of patients and PPE for staff, and insofar as possible dividing infective from non-infective presentations. And this will be also enabled by a rapid test turnaround time, because ward placement is going to be a challenge, because we'll have patients with COVID-19, we'll have patients with influenza, we'll have patients with both. So we can't cohort all respiratory tract infections into one ward. We're going to have to try and cohort based on the bug and isolate when the bug isn't identified. So those complexities are going to really impact on patient flow. We have very challenging times ahead. Next slide. So our standard practices are attendance, admission, avoidance, giving a primary care parallel streams where they actually can see patients via the established community hubs, patients with infection, and try and manage that 80% of cases in the community environment. This will be enabled by GPs being able to complete episodes of care with access to diagnostics, but also access to specialist opinion via virtual clinics or through AMAU, ASAU appointments, and rapid access to face-to-face outpatient appointments. And this is also can be enabled by specialist outreach. And I was going to go into some examples of that, but I'll be very brief about them. Next slide. So one is geriatric outreach, and this is an expansion of the multidisciplinary frailty assessment programs, but to include re-enablement services as facilitated discharge. Next slide. The Inclusion Health Service was very effective during the first COVID surge in maintaining people with service access difficulties well in the community and managing them within the community setting, and this funding will be continued. Next slide. Sorry, next slide, please. Oh, sorry, yes. So another example is of a very vulnerable population as well, was people with chronic debilitating neurological disorders such as motor neuron disease and MS, where hospital-based outreach cared for individuals within their home, cocooning within their home, including instigating CPAP within the home to avoid hospital attendance requirements. And next slide. So yes, change is required, not so much when, because when is now, in fact when was before, but now we need to talk about how can we affect those changes. We've got very clear strategic aims of 80% hospital occupancy, and I think there's a lot of misunderstanding of that people perceive that 20% as being the capacity that surge will go into. But in fact, that 80% occupancy is to facilitate flow. In order to have zero trolley waits, you need to have an empty bed for a patient who's designated for admission as soon as they're so designated. And that's what that 20% occupancy is to facilitate. As Emily mentioned, we need to avoid overcrowding by having alternative options for attendance, and we need to have complicated separated work streams, and that's not just in the ED but throughout the patient journey in the hospital system. The enablers of change will be staffing, maintaining staff wellness, increasing our staffing through the recruitment of all student nurses, recruiting graduates of BSD and HSD who had planned to travel abroad, to offer them positions here in Ireland, and that's something that we're very keen to support. We've offering additional roles not only to medical students, so we've additional interns, but also the people who've just completed their intern year and are eligible for first year SHO positions, offering them increased roles as well. And finally, we will need additional capacity, and that's twofold. One, in a structural sense, through a renegotiated private hospital initiative, and we all recognise the complexities and limitations of that as an offering, but also by identifying and delivering on realistic alternatives to care in the emergency department. So next slide. That's it. Thank you very much. And I'd just like to thank everybody again for the incredible work that they did in the first surge, and just to acknowledge that our mortality rates in terms of critical care are approximately half those of other healthcare systems that were overwhelmed. And that's, you know, a joint result of community efforts and hospital or healthcare efforts, I should say. So thank you all.
Vida, thank you so much for that, and for all our speakers. Is Erica still there?
Yes.
I just have one or two slides I might just zip through, which I think show that we're more or less, if you look at the themes of what's come, we're more or less agreed on the what is needed. And I guess the challenge for us now is to work together to how do we achieve it. That's the slide that I finished with. And next slide, please, in my opening. I don't think we want to get into this kind of stuff, but certainly we need to look at spreading things around rather than congregating people. Next slide, please. So this is a slide that I have borrowed with his permission from Martin Dunn, the director of the ambulance service, which is the future model of care as the National Ambulance Service and really all authorities working towards see things, which is to keep as much care as locally as possible. This specifically refers to when you call 999. I'm about to show you a slide in a moment, not quite yet, where this sits in the top right-hand corner of it. And really what this is about is the inverted triangle, where those needles in the haystack that I mentioned earlier, the most seriously sick and most seriously injured, get identified at the earliest possible opportunity and don't go through the maze of community services, but get brought to the big house, as some people call it, or the specialist care centre as required, but the vast majority of healthcare transactions stay as local to the patient as is safely possible. Next slide, please. This is the second last slide I'm going to show. This is the product of some brainstorming. Emily was leading out on it with us, and many of the other people online, John Ryan and that, about how can we do things differently? How can we control our inflow? How can we look at achieving safe physical distancing? It's been reassuring to hear that we certainly need more capacity. But then, as Gary Courtney would say, capacity is not just bricks and mortar and beds, it is also the staff and the ability to turn the patient around fast. So this slide here really is a put together of the notes that we've agreed out of that meeting. Central there is a patient navigation hub, and really what we would be saying, and I'm echoing Emily now, is that we would have senior healthcare professionals at that hub deciding what is going to add value to this patient's presentation. And I guess the kicker that we're keen to look at is if nothing within the hospital is going to add value to that patient's presentation, and we're just going to triage them to wait in a congregated setting, we might for the first time ever look at sending them somewhere else rather than just streaming them into the emergency department. And the last slide I showed about the inverted triangle of the ambulance, you can see it top right there. National Ambulance Service, we've been in discussion with them. They have many initiatives in development, hear and treat, see and treat, treat and refer, loads of stuff to try and achieve anything other than the automatic requirement to convey that patient to the emergency department. And the arrow coming out on the right there is the specialized services. So the patient has things that can be diagnosed in the field that the patient needs to be brought somewhere else. So it's about spreading it around a little bit. Can I have the next slide, please? So the way that we would recommend working on this is looking at where our patients currently come from, looking at what we can do to tweak the input of those patients, and many of those things there have been referred to already. It's just how we achieve them. Throughput, the patients that we do end up with, how we put them through as efficiently as possible. And I think most importantly is when we see the first signs of crowding. If we get this right, crowding will be visible because it will be a couple of patients who are too close to each other and we have nowhere to put them, and we need the system to help us figure out very quickly where to send them. Can I see the next slide? And I think I'm going to stop there. Yeah, so really that's the natural end of this. I know we still have 135 people online, which is remarkable, an hour and a half down the line, but I want to thank you all for your attention. I have some questions that have been sent in, which I'm quite happy to throw out to the panel. I think particularly some of the questions probably are heading towards Vida and Robert, just to hear the answers to them. Are you both still there to take a couple of questions? Or?
Yes, still here.
Yeah, that's great. So
Still here, Jerry.
Thanks very much. Breda Nadi and Mary Flynn from the Emergency Medicine Programme have kindly grouped them into relevant things, which are ED crowding, radiology gets a mention by itself, hospital capacity, and ED operations, and then others. So the ED crowding questions, there's 5 of them, and there's a similarity. I'll just read out the questions, and rather than ask for an answer to each one. Does the panel expect to see a return to the normalisation of trolleys in the corridor and ED? What supports will HSE nationally make available to hospitals and groups to prevent a return to ED crowding and the nosocomial risk? What is the HSE's position on eliminating waiting in emergency medicine? When will the TrolleyGuard green, amber, red figures be set to realistic values, which should be 1 for amber and 2 for red? How does the HSE propose to ensure social distancing in currently underdeveloped, crowded emergency departments? And the last one is kind of a statement with a question mark at the end. Admitted patients in the ED continues as isolation beds are too few. That probably is a topic which has come up before, that the more modern emergency departments have isolation rooms that the hospitals can't match. So, any comments?
So I might try and address some of those. So there are 2 separated issues as I see it. There's the overcrowding due to trolley waits for patients who are designated for admission, and the plan for that is to avoid that by ensuring an 80% capacity, which we're already exceeding because we're running at 95%. And the enabler for that is supposed to be placed within a private hospital solution and facilitated egress to reduce length of stay solutions. So those are pieces of work that the contract in its current format is to be renegotiated as the solution for that. In terms of the overcrowding in the emergency department and patient experience time, well, a key enabler of that will be the access to rapid access to diagnostics to facilitate a rapid turnaround, but also alternative sites where the episode of care can be delivered, and that would be within the community. So neither of those solutions can be offered immediately, but there's certainly solutions that we can work towards. And in discussion with the HSE leadership, I think the first step is to bring in the relevant parties, including the Emergency Medicine Programme and the IAEM, into discussions about how we can actually affect real solutions to those issues.
Thank you, Vida. Robert, are you resting, or have you anything you want to say?
Yeah, probably just to maybe add a little bit to that, Jerry. I guess the key issues, I guess, are also creating some additional surge and alternative capacity. So intermediate care, we developed a plan which was for 1,351 beds. Now those plans are being rehashed, and we've seen some really innovative solutions come forward. I've just been gleaning through some of the plans today and yesterday, actually. So the key thing is, if they get funding, I think they'll add real value, and there's a real potential for some of those options to offer streaming options from ED, and arguably some streaming options from primary care or community assessment hubs as an alternative to ED. So I guess trying to prevent all people who currently attend ED attending so. But at the back end, I think it's probably also fair to say that we really do, and I know I touched on it earlier on, we really do need to tackle the issue of effective discharge management. And that means, I know one of the questions that was asked was about the safer bundle and predicted date of discharges. When we reviewed 9 hospitals, it was very clear and apparent that those recommendations, which have been in the system since 2013, are not necessarily in use everywhere, but they can certainly play a role in terms of creating some capacity, in addition to targeting length of stay and also supporting the increase in capacity. So I guess, building on what Vida is saying, it's a combination of reducing demand, increasing throughput, speeding up egress, but also creating new capacity, as well as securing it from the private hospital sector, which, as we know, is going to be a temporary solution.
And just to perhaps add, maybe a longer term solution is by implementing the APHIS project. We then have a data source that would allow us to have empiric information on what our patients, or at least what the patients who are attending the ED need, so that we can look at alternative sites and ensure, alternative delivery models, and ensure that they have the resources that those patients need to deliver on their care. Because there's no doubt people are going to the ED because that's where they perceive they'll get the care they need.
Okay, thank you. You guys have seen the questions, have you, Robert? I know that you've seen them, obviously, from your answer. I think you've already touched on this question, but I'll ask it anyway. When will there be an assessment of the true acute hospital capacity in the new COVID normal? If 6 beds will only operate as 3 or 4, what will be the impact on acute capacity? I think from previous conversations we've had, you're working on that figure.
Yeah, so there is an exercise ongoing looking at what the impact of implementing a 2-meter distancing rule would be, and I have to say that my view is that everything that we do in medicine is a risk benefit, and for every action there's the potential consequence. So complying with the 2-meter rule, well, first of all, there's no absolute science. We know that 2 meters is better than 1 meter, but 5 meters was probably better again. So what are the risks of implementing the 2-meter rule? On our preliminary assessment, it would appear that we could lose up to 20% of our capacity. Now, if we were to do that, that will exacerbate our ability to deliver on patient flow. It'll exacerbate overcrowding in the emergency department and in the emergency waiting rooms. And in my view, those risks need to be balanced against any potential gains from implementing a 2-meter rule that can be mitigated by other infection prevention control strategies. So that's something that we're quantifying at the moment, so that we could then do a risk-benefit analysis. So that's the status of that piece of work at the moment. It's an exploratory piece.
Thanks, Vida. There's a lot of really good stuff coming up here, but I guess reflecting on John Ryan's last slide, crowding is back in some places. And
yeah,
I think one of the concerns that we have is the connection between yourselves in Dr. Stephen's Hospital and the hospital management, and to what extent crowding must not happen.
Yeah, so in the absence of an alternative, crowding will occur for healthcare provision. So we have long-term and we have short-term strategies. And what we do know in short-term strategy, that lockdown restrictions work in decreasing emergency medicine attendances. So the question is that associated with an increase to the patient in terms of morbidity and or mortality associated with non-attendance, or is it that it's low acuity patients who without specific care, have their problems have resolved? Certainly the data to date doesn't show any excess mortality in Ireland from non-COVID related conditions, which is reassuring, but I suppose it's not by no means the final picture. I cannot see us managing a surge either in between now and Christmas or over the winter period without the support of lockdown restrictions. That's my personal view, and that's the advice that I will be giving to the system. But we're just starting to engage in those winter planning discussions. But I think we need to identify what the triggers for those lockdown will be, and they will be related to not only disease incidence or prevalence in the community, but the consequence in the acute hospital system in terms of hospital admissions and occupancy rates and critical care admissions. It's likely to be combined.
Thanks very much. We'll be coming towards the end of the questions now, but there's a theme coming up here, which is that this is my paraphrase: everything that used to be straightforward now takes longer to do in the COVID era, and part of that is PPE, and part of it is having to manage 2 additional separate ED streams. And I guess the extent to which that's accepted as the new reality, and therefore I know we want to try and stop the patients coming in the first place, and we will continue to work together to do that. But if you have to do, and there's a couple of emergency departments around the country where really they have just had to split into teams without any additional resource whatsoever. And do you think that's recognised by the system as an issue, that you can't be in 2 places at one time?
I think that the system is taking a big sigh as if it's somehow over, and it needs to be reset to realise this is not over. This is a pause that allows us to regroup, to learn from our first surge, so that we can be even more effective going forward. So I think that yes, separation needs to continue. I think if possible, a model that flex up and flex down based on demand is useful, but that's not always going to be possible.
Okay, thank you very much. I'm really reluctant to ask 111 people to unmute and ask any questions. I'm going to start drawing it to a close, but if someone wants to come in with something fast, we might get away with it.
Jerry, I wonder, just Robert here, I wonder if I could maybe just offer a comment as well in terms of where we are and where we might be getting to in terms of progress.
Sure.
If I just very, very quickly, Jerry, reflect on where we were last September, both in terms of activity, in terms of attendances and admissions through the emergency departments, and also delayed transfers of care at the other end. And if I give you 2 startling numbers, last September on a Monday, it wouldn't be uncommon for ED attendances to land somewhere about 3,900. Yesterday, ED attendances were 3,900. Last September, we would have had about 670 or close to 700 delayed transfers of care, which would have cumulatively consumed about 55,000 bed days. So they were prospective bed days that were being lost to the system. Today, that number is 19,000. And when you look at where trolleys were in ED and basically ward trolleys in the house in September last year, basically, you know, the cumulative number was probably somewhere close to 600. Today, it's less than 200. So we do have overcrowding today, but I guess what I'm saying is that we've demonstrated that we can make progress in, you know, certainly through winter and as part of COVID. So that would give me hope that we can make progress going forward. But there's no magic bullet. It's got to be a range of a number of things that we've discussed here this evening.
Jerry, can I say something? It's Emily here.
Certainly, yeah.
So it's just to emphasise the urgency of HSE Central setting down some of this for us. Emergency departments around the country are literally, as we speak, juggling with the competition from scheduled care, space being taken back, clinicians being taken back, and many of them are being told that there is no money for any social distancing and to continue the streaming as it's been done. So getting a standard from HSE Central urgent, you know, is really urgent, or else places are going to be reconfigured in ways that we won't be able to roll back on when things spike again. Thanks.
Thanks, Emily. I guess and this is not new, this issue, but it is more real now. The difficulty in translating the, if you like, aspirational stuff, the design, the model of care centrally, which is to describe what good looks like. It is designed by those of us working on the front line. It's agreed. And then there's a middle bit where you have to translate that into any individual hospital's service delivery plan. For years, we all know that the pressure release valve of stack them high and double them up if you have to in the emergency department. We'll figure out tomorrow what to do with them. I think it is appreciated that Ireland has had a trolley problem in terms of numbers and duration of individual patients on trolleys like no other system. And that's what's regarded as what emergency departments are for by many managers on the ground, it sometimes appears. And I think that's the bit now, to what extent when we see crowding happening in front of us, can we demand that it be dealt with in the moment? It starts with us trying to see is there any way of resolving those patients being too close to each other, but it then requires people stepping up to the plate immediately to try and resolve that crowding, rather than say we'll figure it out next week and do a root cause analysis afterwards. I think
well
that's
said.
I think that's the fear we have, that if we don't grasp this moment, it'll all just go back to the way it was, because that's what people are conspiring to do. On that happy note, I don't see any other questions coming at me. I want to thank all of our speakers for providing, I think, a tableau of what's out there, what the challenges are, giving some level of reassurance that people hear what the issues are and that there are plans to deal with them. I think, as Emily has just said, it's the immediacy of it. I think we want to work together, but I think there is a reluctance to return to just tolerating crowding while we all get on with other stuff. And I think that's the bit holy grail, that if we can just grasp that and succeed in getting rid of that, good things will happen.
Jerry, can I just say that the communications from the IAM with the INMO, and then more recently just from the IAM, have been received and heard and accepted, and really it's now a case of how do we address those problems.
Okay, that sounds like a note to finish on, I think. And again, I want to thank you all very much for your time, and the audience for their listening and their questions. And hopefully we'll move forward together on this. Thank you very much.
Thanks, Jerry.
Okay.
Thanks, Jerry.
And thanks, Eric.